Hello, I'm Warren Hall, the National Manager of Support Services for the American Liver Foundation. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice and an ear for patients, their caregivers, and their families through education, support, research, and advocacy. I want to welcome you to this installment of our Ask the Experts series. We developed this long-running series now because we heard and continue to hear from so many people who say they either forgot to ask their doctor a question during their appointment, or they realized on the way home that there was something that they didn't quite understand. So we thought it would be helpful if we brought in experts in the various fields related to liver health, disease, and overall wellness, so that we can ask them those questions. Now, our guests today are not members of our personal medical teams, although we probably wish they were, so they may not speak to your exact situation or tell you what to do. Only your own healthcare team can do that. But all of us will get a better understanding of the complex world of nutrition as it applies to the liver. Now, I'm excited about our discussion today because when it comes to the liver, nutrition is how we keep it healthy, and nutrition is how we treat it if there is disease. And we have two of the best experts in this field with us today. So without further ado, I want to introduce our guests. First is Carlene Welles. Carlene is a registered dietitian and a certified clinical transplant dietitian with over 20 years of experience in clinical nutrition. She spent her first 10 years as an inpatient registered dietitian, covering various disease states. She has spent the last 12 years as the transplant registered dietitian for one of Philadelphia's leading transplant centers. As the outpatient dietitian, she's responsible for providing nutritional care for patients who are undergoing evaluation for heart, kidney, liver, or pancreas transplant, as well as those who are being evaluated in order to be a living donor for the kidney or the liver. Carlene is also a consultant in private practice in Philadelphia, where she provides nutritional counseling regarding a variety of disease states, such as diabetes, renal disease, obesity, hypertension, and cardiovascular disease. And also we have with us today, Kristin Kirkpatrick. Kristin is a registered dietitian who now lives in Colorado. She was the manager of the wellness services at the Cleveland Clinic's Wellness Institute in Ohio. She's an author, public speaker, and wellness consultant. Her best-selling book, Skinny Liver, is currently the go-to resource for those with fatty liver disease. The American Liver Foundation recommends this book not only to those who have been diagnosed with fatty liver, but for those who want to prevent it. We also recommend this book to those who have various types of liver disease, as the dietary information contained in it can apply to them all. So now I can't believe that we were able to get both of you in the same place, sort of, and at the same time, as you're both so busy in this very important area of nutrition. But we thank you both so much for making the time.
Thank you.
So Kristin, we know that you're going to have to step away from us a little bit later. So I want to turn this over to you first. We came across your work during a spot you did for NBC Today. I believe it was in October of 2018. The title was, "Do You Really Need a Liver Cleanse?" Now, spoiler alert, you don't. But in that article, we also became aware of your book, Skinny Liver. And as I mentioned, we now recommend this to everyone. So thanks for being with us here today. And I'll turn this part of our discussion over to you.
Okay, thank you so much, Warren. And I'm honored to be here with my colleague, Carlene, and then with you, Warren, and of course, the Liver Foundation. And the reason that I think this is so important, and you really touched on this, Warren, is that if you don't have NAFLD or you don't have any liver problems, then you know someone that does. You love someone that does. And it's possible that you have something going on as well that you might not even know about. And the only reason I say that is not to be an alarmist, but really to look into this huge prevalence that we see is impacting our liver and our liver health. Individuals who really did not recognize that perhaps something was going on from a metabolic perspective until liver enzymes were increased, and then started asking, oh my gosh, what does this mean? Why did this happen? So we do know that almost 75 to 80% of type 2 diabetics probably has some form of fat that is abnormal in content in the liver. So this is really something that touches us all and is so important. And to your point here, we really don't have, as far as the non-alcoholic fatty liver disease, we don't have a pharmacological approach. We don't have the pill. We don't have that perspective yet. And so diet is really the role that we want to take in order to look at reversing this condition. So I'm really happy to talk to everyone today that's watching. And again, I feel, of course, everyone on our panel today, our favorite organ is the liver, of course. I mean, I'm saying something that's a statement of the obvious. But I think the point here is that for years, I have seen all the stardom go to the brain and the heart. But I think people don't realize that if you were really focusing on your liver first, all of those other organs would be benefited. So we really have to look at that as well. And really to the point of what you talked about with the spoiler alert, do we need a liver cleanse? And no, of course we don't, because we were given this beautiful organ at birth that actually does that for us. But we're not really taking care of it to the extent of which we should be. So I'd like to share my screen because I have a few slides for everyone here. So let me just get to that. And play from start. Okay, so hopefully everyone can see that. So I'd like to start off with really looking at what is the best diet overall. Okay, so let's take the liver and put it off to the side, and let's just look at what's the best diet. I'm sure Carlene gets this as well. I get this question all the time. People will come in and say, well, what do you think is the best diet? What do you think is the perfect approach? And no one likes my answer because it is as uninteresting as you can get. But the best diet for you is going to be one that you can sustain long-term. So I think we need to start with that really high level perspective. So even though something may have worked for your sister or your neighbor or your friend, it may not work for you. And there's a lot of different factors that get into that. There's genetics. So there are certain genotypes that make a certain dietary pattern work better for other people. There's your environment. Who do you live with? I remember I had a non-alcoholic fatty liver disease patient come in to see me at the Cleveland Clinic. And this person was highly motivated because they were already in the latter stages of the disease, yet still in a stage that was reversible. They really wanted to make these dietary changes, but their spouse was not willing to change the food in their house and not willing to change her dietary perspective. So the sustainability really goes down for that patient. So again, this is something we have to look at, not to say, hey, let's get rid of our friends or our spouse, but how do we find that support in terms of looking at that sustainable option? So let's just start there. Let's look at this perspective of what can we stick to, not in the next 3 months, not in the next 6 months, but the next 6 years. Because the key factor when we look at all of the data relating non-alcoholic fatty liver disease is weight loss. So weight loss is going to be such an important perspective of trying to prevent this condition or reverse this condition in the stages where it is still reversible. So I think from a weight loss perspective, I became a dietitian because I was overweight. I went to go see a dietitian. It really was something that was ingrained in me very early on in life. And what I found, and what I know a lot of you have found as well, is that losing the weight is challenging, but it's nowhere near as challenging as keeping the weight off. So that's why this sustainability has to be there. I want my patients, and I want all of you watching today, that we're going to focus on health. And if we focus on health, we're going to lose weight in the process. But we also want to focus on keeping that weight off long-term. That's a really important factor. If we reverse the fat in the liver, I want that fat to continue to be reversed and not go back or yo-yo back and forth in terms of what that looks like. All right. So first of all, your dietary considerations are going to, number one, be dependent on the stage. So as I mentioned briefly, we do have in the first few stages. So let's say you've just been diagnosed with non-alcoholic fatty liver disease, and the diagnostic techniques are all very different, by the way. So some of the physicians I've worked with will simply look at the fact that an individual has a high hemoglobin A1C, which is a 3-month marker of blood sugar control. They also have central obesity. So having more fat distributed in the central region versus the butt region and the thigh region. Okay, so that's central obesity. It's more active, has more cytokines, more inflammatory, and quite frankly, much closer to organs. Okay, so they'll look at that. And then if we also have the addition of some laboratory work showing that our liver enzymes are off, many of the integrative physicians I've worked with will assume that you probably have some sort of non-alcoholic fatty liver disease in those first stages. Some individuals may go further and get an ultrasound. Some may go even further to look at biopsy. But when we look at this standpoint of diagnosis, sometimes it is a diagnosis based on a hunch of other different factors. So you're probably looking at more of a stage 1, stage 2. So you have, let's say, more than 10% of your liver has fats, which is where we start looking at non-alcoholic fatty liver disease. So that first stage is, hey, you've got more fat than you should. Let's try and reverse it. The second stage is, oh, you know what? Now we've got a little bit more fat, but we also have some inflammatory factors going on. We have a little bit of fibrosis. Still reversible at that point. It's when you get to those latter stages where the inflammation and the scarring takes over, where we don't have that reversal capability anymore. So I know that my colleague Carlene is going to talk about that more in depth when she goes into some of her dietary perspectives, because she's got that clinical experience. But I'm going to talk about the places where we can actually reverse this condition and how great that feels. So number one, it's going to be dependent on stage. Once you get to those latter stages, you're looking more to transplantation than you are the dietary approach. And the dietary factors really do change once you get into that. So Carlene will touch on that. The other thing is, regardless of what you do, there probably is some sort of fasting mechanism that should be implemented. I'm going to show you a slide in a few minutes that really does show some of the benefits we see to reversing some of the fat in the liver based on simply some fasting mechanisms. So we know that when we look at fasting, there's many different approaches. Many of my patients with NAFLD tend to do well with something called time-restricted eating, which is limiting the hours in which you're eating to 8 hours a day. Now you can do 10 hours as well, but when we look at studies on NAFLD and time-restricted eating, we do know that our metabolic profile tends to improve. We also know that liver enzymes tend to improve as well. Does help with weight loss. And so that's probably, it's the chicken and the egg approach where we say, okay, you've lost some weight. So that might be the other reason why you're starting to see some of these benefits to these liver enzymes as well. Who shouldn't look at fasting if we're watching this? Someone who is really uncontrolled, severe type 2 diabetic, obviously a type 1 diabetic. If you're on insulin, that could be problematic. And for obvious reasons, right? We need to have regular points in the day where we're actually providing fuel to offset what's going on with our medication. But if that's not you, then fasting really does speak more to our ancestry and how we are supposed to eat. I often tell my patients that the body is out for survival. It doesn't care about your plans. It doesn't care that it's January 1st and you've made a New Year's resolution. There was actually a study that came out last week showing that about 2/3 of individuals that have made New Year's resolutions have already dropped them by the end of January. So that's a great point in the fact that the body doesn't really get a January 1st obscure date, right? The body also doesn't get that you're living amongst a world where food is available 24/7. So while it's natural that we have gotten away from our ancestors, we're no longer have to walk out of our front door and try and kill something, and that might be our only meal today. Now we can just get in the car and go to a drive-through. Body doesn't get that. So what we have to do is incorporate some fasting mechanisms so the body can get back to that. That also helps with circadian rhythm as well. And we know that there are some studies linking an abnormal circadian rhythm to a worsening of non-alcoholic fatty liver disease as well. So there's a lot of benefit we can do there. So again, I'm talking very high level here. We want to look at, okay, what's going to work for me long-term? And that might mean, all right, hey, I got to talk to my spouse. I have to talk to my kids. We're going to start eating better as a family. That might help me long-term. Then what kind of fasting mechanism can I utilize? Can I simply limit the hours to 8 hours a day? Can I eat from 11 to 7? Will that work in my life and everything else going on? All right. And then we can look at that weight loss perspective. Now, when I think about weight loss for my patients, if you were to see me at Cleveland Clinic, you would have come into the office, and every 12 weeks, we put you on this huge machine that's really expensive and no one would ever have in their bathroom. But this machine looks at each arm, your central region, your trunk, and then each leg. And it looks at the fat, the water, and then the muscle in each of those different quadrants of the body. So obviously that's a really expensive machine, but we can look at other mechanisms in terms of how to determine weight loss. I feel like as experts, we're often telling people to lose weight, and then we don't tell them the best way to measure that. So again, the scale is simply a perspective of your stuff. And when I say stuff, it doesn't differentiate between fat, between muscle, between water. It just looks at this number. That's it, right? So a better assessment, especially looking at that risk factor of central obesity, is waist circumference. So you really want to look at waist circumference as one of the main determinants of whether or not you're going to be in a better place in terms of weight loss. If you don't have a tape measure, I was doing a survey of a bunch of patients just last week, and I talked about waist circumference, and I said, how many people have a tape measure? And 0 people had one in their house. So most people don't have that. So if you don't have a tape measure, I oftentimes say that if you have an old pair of jeans, old pair of pants, that's a great assessment of whether or not you're losing fat in that central region as well. And I know I have an old pair of jeans, definitely somewhere hidden in my closet, that if I need to look at reducing belly fat and things like that as a middle-aged woman, I'm grabbing those jeans. We all have them. Okay. So that's another great assessment of how to do that. It's just simply the waist size and looking at what that looks like. Again, remember, if you think about risk factors, both prevention and early stages, central obesity is a main risk factor. So again, and that's more of an apple type of approach. So if you gain fat in that central region versus the lower regions, which is more of a pear, that's a lot more of a risk factor for NAFLD. So we have to make sure whatever approach we take is going to ensure that weight loss. We also have to know that whatever dietary approach we take is going to have some impact on insulin and blood sugar control, because the liver plays such a gigantic role in both of these factors. And because NAFLD is so sensitive to insulin sensitivity, what we have found in the past 18 months to 24 months are multiple studies showing the benefits of a lower carbohydrate approach to reversal of NAFLD. So I'll talk a little bit more about that when I get into my next slide and then the final slide. But we might want to think, okay, here's my algorithm. What's my stage? What's my environment? What kind of fasting can I do? And now, where can I keep my carbohydrates? What does that look like for me as a patient to be able to get a better handle on blood sugar control and insulin control? And then it's going to be dependent on you and your why. So what does that mean? When my patients come to see me, I tell them that they need to give me 3 different whys on why they want to lose weight. And only one of them can be vanity-based. Vanity is totally fine. That's a good motivator. But when we look at studies on behavior change, we know that the vanity doesn't sustain that behavior. What does sustain it is, I don't want to progress to cirrhosis. I don't want to get liver cancer like my grandmother did. I don't want to get dementia. I don't want to get whatever. I want to get on the ground and play with my grandkids. So you have to determine that why. Maybe write it down, maybe put it on the fridge, maybe just share it with someone, maybe write it on your mirror every morning. But remember that even in the early stages where you perhaps can feel nothing, your liver could still be screaming for help. So we have to keep that why in the foresight of, hey, This is why I'm doing this for you, because if you don't work, if that liver doesn't work, nothing else will. So let's give it the credit it deserves. I did say in my book that the liver was like Rodney Dangerfield, where he used to make jokes about how he gets no respect. Gets no respect. So we need to start respecting it a little more. It's easy, right, to forget about it because we can't feel the symptoms in those early stages, but it doesn't mean that it's not reaching out for help and we're ignoring it. We ignore it too long, we get to those stages we don't want to be at. This is a slide that I think is really important, just looking at the benefit of what I would call a baby steps approach. So again, when patients come to see me, if they come in and off the bat, they're like, I'm here to see you because I want to lose 60 pounds. I'm not going to touch that 60 pounds. That 60 pounds is unattainable on day one, but 2 pounds is attainable. So we focus on 2 pounds every week, every few weeks, whatever the case may be, and everyone's different. Just as every diet is different, everyone is different from this perspective. But you can see here that if you just look at a very minor amount of weight loss, just a minor amount, you can start seeing improvements in liver fat. You can start seeing this decrease of liver fat. We also know that when you get to greater amounts of weight loss, so greater than 10%, that's when we start seeing this inflammatory factor, this fibrosis go down as well. So really, let's think about this again. Let's take out that concept of the scale. Let's think more about waste, and let's think of this as percentages. And that's why I made that example about how the vanity reason. I've got a great one because I have my brother getting married soon, and I've had people in my family who have said, well, I just need to get into this dress for the wedding. That's all. I just need to do that, right? That is not a good enough reason, and it won't be sustainable. So we need to look at this more in the terms of the percentages. I need to lose this percentage to really get my liver to where I'd like it to be. All right. I also want us to think, before I go to the next 2 slides and my last 2 final slides, more high level of eating more food. So before I get into more of the specifics in the next 5 or 6 minutes, before I turn it over, food is going to be a really important concept. How do I define food? Well, I stole the definition from Michael Pollan, which I think he's got the best definition I've ever seen. Food is something that comes from nature, is fed from nature, and will eventually rot. So let's think about what your diet looks like. When you look at the next 2 slides and you say, okay, I think I'm going to take a Mediterranean approach and maybe I'll do a little bit more low carb. What percentage of that is food? Right? What's coming from nature? What's fed from nature? We can go really obvious and say, of course, an apple is going to be food, and maybe an apple energy bar will not be. That's an obvious one. It can get a little bit more difficult and a little more challenging when we look at animals, though, and animal products. So under this definition, if you're someone who struggles with reducing the consumption of red and red processed meat, and that is a really key factor in being able to reduce liver fat. So it's something I want you to consider. But let's say you want to stick with this definition of food, then really wild meat is going to be the best place to go. So maybe bison or maybe venison, because it's feeding from nature. It's not feeding from grain. So we could really get into the weeds. We could talk for an hour about how you define food. But when you think about this high level, I want you to base your diet off of whatever the structure you're going to choose after today, after hearing me and Carlene. And then I want you to look at, okay, 80% of that, or even 90. I think you could do 90. I think you're better than 80. 90% of that is going to be food. 10% is going to be the outside of that. Okay. It's not the 10% where we have a donut on Sunday morning that is going to make our liver start saying, like, please help me. It's when that donut becomes the 90. Okay. So think about that. You can still have foods you love. I don't want us to look at food as good or bad, but I do want us to look at it as food and non-food. That's a better way to look at it. And you can have that 10%. You can have the piece of pizza. You can have the donut, but that falls into that 10%. So that's why working with a registered dietitian, of course, Carlene, we're both biased here. We think you should be working with a registered dietitian. That's why working with one is so important, because a dietitian can really help you determine, okay, based on all these factors, here's what we think is going to be the best way to do this. And you know what? I'm looking at your diet and your diary, and that's not really food. That's going to go in your 10%. So they can really help you break that down. All right, so let's look at what has remained the best diets, study after study after study. And there was just another study about 2 weeks ago looking at prevention and also looking at reversal of fibrosis, that inflammatory factor. It is the Mediterranean diet. There are very few outside of Mediterranean approaches that can really show a gigantic benefit to NAFLD or just general liver health. Okay, so instead of that cleanse, this is what we're talking about. Let's look more at a Mediterranean approach. So obviously, a Mediterranean approach is going to be higher in monounsaturated fats and polyunsaturated fats. It's got a lot of folate, fiber, and antioxidants. We actually used this slide in a presentation a few months ago for, I think it was Today's Dietitian magazine had a webinar. And so it was myself and a hepatologist that were doing a presentation. We really focused very heavily on this Mediterranean diet approach. And this is one of the slides we showed. Low in saturated fat. So when I talked about the red meat, the red processed meat, butter, full fat dairy, we do know that that is a component of the Mediterranean diet. So something to think about. The other thing with Mediterranean diet is it's very high in antioxidants, very high in polyphenols. I had mentioned at the beginning of this presentation that when we look at improving our liver and what that looks like in our liver health, we end up improving the entire body. So the Mediterranean diet and its counterpart, the MIND diet, which is a combination of Mediterranean and DASH, also has been shown to have significant improvements in cognitive health, brain health, heart health, everything. So let's think about our body and all the factors that go into it and what's the one thing that might work for us. So I do think that's a Mediterranean approach. Now, I've also said that limiting carbohydrates can also be really beneficial as well. So you may look at the Mediterranean approach and think, well, isn't that very high in whole grains and legumes? And isn't that a high carb plan? Well, it can be, but again, you can work with a dietitian to really take the carbs, limit them to 45% of overall intake. And now you've got a moderate Mediterranean diet approach. Let me give you a quick example of what that might look like. For breakfast, you might have something like egg whites with a whole bunch of colorful vegetables. That could be a great breakfast, and maybe one piece of sprouted grain bread. Maybe you have some steel cut oats and you put in a little bit of hemp seed into that, or some nuts to get some omega-3 fatty acids or some extra monounsaturated fats. Maybe a few berries. That's a low glycemic load fruit. So now we're talking glycemic load and limiting carbohydrates by choosing fruits that have less sugar overall. Okay, so these are some approaches that you might consider for breakfast. For snacks, it's hard to beat nuts as a great snack. I mean, what a fabulous snack. Nuts are a great snack, low carb, very in line with the Mediterranean approach. I love apples as a snack. I love a bowl of berries as a snack with some low-fat yogurt. So then that yogurt helps get in those probiotics. And again, we could talk for an hour about this, but we do know that getting probiotics in, getting better gut health can actually help with NAFLD as well. And then for our lunches and our dinners, we can look at lean sources of protein. We can look at some organic soy. We can look at fatty wild fish like salmon. We can look at having a beautiful salad. But the key here is that we could take that Mediterranean approach and really put it in such a perspective where our carbs are lower, moderate, or even what I would consider to be low carb. So this last slide does really give some of those definitions. We have multiple definitions from multiple organizations actually looking at the percentage breakdown of carbohydrates. So for the most part, let's just stick with these numbers. Moderate carb is going to be about 45% or less of your total calories coming from carb. Low carb is going to be about 25% or less. And then very low carb, which I would say very low carb, I put a slash there and put keto. That's going to be probably less than 10%, 5% in most cases. Okay, that might not be as sustainable for some people. That might be too difficult. And if you're not working with a registered dietitian, you might be getting a little bit too much saturated fat in that approach. So we have to look at that as well. We also know that when we look at carbohydrates reducing, and we look at a Mediterranean approach as well, there's also some benefits with limiting calories. Now, I would never recommend people go 450 or 800 calories a day, not sustainable, and in a lot of cases, not safe, despite the fact that we have improvements in weight loss. Of course, we have improvements in weight loss. I don't want anyone doing this, but I will just remind you that if you eat 500 calories coming from Oreos every day, hey, you're going to lose weight. Yes, because it's a calorie thing, and you're not getting enough of it. But that's not the approach we want to take because you won't sustain that. So always remember that sustainability. We also know studies look into preferences, both cultural and religious, as well as just personal preferences. You choose diets that are more in line with those preferences, you're more likely to stick with them long term. So let's think about that as well. But if I'm looking at some main factors that I think are going to be really important, improved insulin resistance, lowering glucose levels, improved NAFLD. I'm really looking from this chart. And again, this is one of the charts we did for that Today's Dietitian presentation. I'm really looking at more of the Mediterranean or DASH approach, one of those. And I'm looking at probably keeping those carbs at 45%, maybe 30% or lower to try and achieve some of these benefits that we see on this slide. So, we're probably going to come back and talk about more at a different time because we could talk about all of these things in a lot more detail. We could talk about more probiotics. We could talk about what food looks like, how to eat more food. We didn't touch on exercise, or I didn't touch on exercise. Carlene might, but I have not. But we do know that getting just 10 minutes a day, there was a new study that came out, just 10 minutes a day of doing some sort of physical activity. I don't like to use the word exercise. I like to use the word movement, because I think that's more attainable for people. Just move, just be more horizontal than vertical. But just getting 10 minutes a day can actually extend our lifespan. And we know that doing exercise actually helps with insulin sensitivity, which in turn helps with improvements in liver health as well. So I'm going to turn it back to Warren, but it was just such a pleasure to talk with you. I had to stay high level because of the time frame that we have today, but hopefully you have some perspective of how to structure what you want to look at from your liver healthy diet. And you're going to call or find a dietitian within your area after this, this Ask the Experts approach, so that dietitian can help you reach those goals.
Well, Kristin, wow, thanks so much. So a couple of my own takeaways here, about the food there. The quicker it can go bad, the better for you. That was somebody had said, if somebody says, here's a loaf of bread, it can last about a year. Stay away from it. So the quicker something can go bad, the better. And the other important thing that you mentioned too is that our liver, and this is probably what Carlene will get into this, our liver can't tell us something's wrong, right? The liver does not have any nerve endings. And so unlike other aspects of our body, when something's wrong, we don't know it. That's why liver disease can be a surprise, and so, and then, when you did say you had to stay high level, of course, but what I've done, even with the Skinny Liver book, now the third part of that has recipes. I've looked to see what the ingredients are, because people ask us all the time. They get very specific. They'll say, what kind of salad dressing should I use? What kind of cereal should I eat? And, you have to, there's millions of individual foods, right? But the thing to do is to use those high level guidelines, that you had mentioned there, how close is it to the earth, and then that could guide us in what is important for us to have. So,
yeah.
So really, thank you so much for that. And the other thing too, there's a psychology to food, right? To eating. I'm an eater. I have friends who are diners, and there's a whole difference in what that does to us as well. So those things are important as well. Kristin, if people wanted to look up some information, where can they find you? Where can they find some further information if they want to dive deeper?
Yeah, they could just go to my website, which is my name. It's KristinKirkpatrick.com, Kristin spelled with an I. And I think, the one thing I will say that I didn't mention, but I think is such a critical component, just from a time perspective, is also alcohol. So, if we look at the fact that we're looking at non-alcoholic fatty liver disease, at least those are the bulk of my patients. I'm not really working with alcoholic liver disease. So it's really the lifestyle associated liver disease. But I do think that the CDC and the American Heart Association guidelines, as far as the upper limits, are too high. I think that to say that a woman can have a glass of wine every single solitary day, that might be too high for someone who is experiencing elevated liver enzymes. That's not to say in these early stages we can't have alcohol. We can, but I just think like maybe every single day might be too much. And the reason for that is not so much that having a 5-ounce glass of wine is literally too much. We just don't have the 5-ounce glass of wine. If you were to take 5 ounces, measure it and put it in there, you're probably having 9 to 10. Okay, so that's the thing. It's just like, I'm not disagreeing with the mechanism of the CDC and the American Heart Association, but the fact that we think people stick to that portion is unrealistic, because most people are not measuring that. So I think that's another thing just to think about and to talk about when you're in those early stages. Right.
Well, thank you. And we're definitely, as I mentioned, we're going to get both of you back. So we know that you have to jump off here shortly, but again, thank you so much. And we're definitely going to have you back again.
Thank you. It's an honor.
Thanks. So Carlene, now we're going to move many of those who are viewing this. Many of these folks are those who already have liver disease. So much of, although what Kristin was presenting is about those with fatty liver and stuff, or how to prevent getting it. But now your area of expertise, now you're dealing with folks who may be further down the line here, even to the point of transplant. So I'll turn it over to you now to, for your insights into what the information those folks would need to know.
Great. Thank you so much, Warren. And Kristin, that was a wonderful presentation. I often do like listening to my colleagues. You always get a new perspective, excuse me, on things. So definitely thank you for that great presentation. As Warren mentioned, I'll definitely will be doing something a little bit more clinical, focusing. Let me share my screen here. Are we seeing the presentation?
It's a little off to the side.
Okay, let me get that together. When you're working with the multiple screens, it's usually hard.
That is a beautiful screen. Looks like a flower.
Let me think. I'm trying to make sure it's on my in front of me versus, okay, here we go.
Yep.
All right. Okay, here we go. We'll put you up top there. As Warren mentioned,
we can't see it just yet, so I think.
Oh. Now?
Not yet.
Okay, let me stop sharing.
I know I have 2 screens. I usually just shut the second one off because I get all confused.
Okay, let's see. How are we now?
Perfect.
There we go.
Okay, wonderful. So as mentioned before, just really diving into more so the malnutrition and advanced liver disease, and then touching base on nutrition after transplant. What are some of the things we have to be mindful of? I saw this graphics here in one of the articles during this research for this talk. And I thought it was just a perfect representation of as I said, the progression of liver disease. As Kristin spoke about these first stages here, when, the healthy liver to where we are at the fibrosis, when they are reversible, right? Mainly when I see my patients, they're on this side here, over with the cirrhosis, which may lead to hepatocellular cancer, HCC, in that end stage area coming for transplantation. With cirrhosis, the liver can we categorize as compensated, where it's still healthy enough to be doing the regular functions, okay? Not much side effects or symptoms of liver disease. And then we can lead to what we call decompensated liver disease, where we are having those common side effects, the complications. You may have ascites, your water holding onto your stomach. You may have the encephalopathy, the confusion, okay? And so many other things can happen. All that can lead to what we call protein calorie malnutrition. and then also some micronutrient deficiencies. So those are our vitamins and mineral deficiencies. Malnutrition, what is that? I know we throw that word around all the time. It's basically the lack of enough nutrients in the body, okay? This is one of the most common complications for a liver disease, advanced liver disease, despite of what that cause of liver disease is. Further, I will be reviewing, just touching on a few of different liver disease and what type of micronutrients deficiencies related to those. About 50 to 90% of our cirrhotic patients have some form of malnutrition, and then females tend to have more malnutrition than males. We talk about what are the causes for malnutrition. You know, you're not getting enough intake in by mouth. We see several reasons here: the appetite. We spoke about the ascites. You just feel full. You may hear the word early satiety. So we're just getting full quickly. So we're basically not getting enough nutrition in our system. Some of our dietary restrictions may be causing, you know, decreased intake. As Kristin mentioned before, you know, the liver is involved in basically everything that we do. It processes our glucose, our fat, our protein. When the liver is not working properly, this all changes. Changes in our eating pattern. And as she mentioned before, that insulin resistance is a key with our liver, how well our liver is able to use insulin to function. Some other issues that cause malnutrition in liver disease: malabsorption. So bile acid deficiencies, we have some bacterial overgrowth, and also just the liver's capacity or ability to store some of those nutrients. Here, I'm just touching base on a few of liver disease that really have an impact on your nutritional status. Alcoholic liver disease, or ALD. One of the, you know, liver is a primary place where alcohol is metabolized. As Kristin mentioned about, you know, alcohol, we do not drink the 5 ounces. You know, we're easily up to 7 to excuse me, 10 ounces of wine in, you know, per glass, right? And then we end up may having 2 glasses at a time. And as little as 2 weeks, we can see some changes. 2 weeks of regular alcohol use, we can see changes in your liver. What happens when there's excessive alcohol use? We're basically replacing nutrient-dense food, right? So we're not eating, we're not having you know, the 3 meals a day or anything like that, because we're replacing that food with the alcohol. Alcohol liver disease carries so many nutrient deficiencies, you know, listed here. As we go on in the talk, I will be providing just some of the sources and how we can replete these nutrients, okay? And no magic pill for alcohol liver disease. It's basically your abstinence from alcohol, changing your diet, providing adequate protein, and then making sure we're repleting those mineral and vitamins. In my work, we've seen patients, they come through for transplant, you know, they no longer can, you know, we have our criteria of abstinence in order to qualify for a liver disease. We have some patients, when they become abstinent, their liver enzyme and their liver health improves so much that they no longer need that liver transplant. Hepatitis, it's a whole slew of them, A through E. Hep C is one of the more common that can cause liver disease. As mentioned before, you know, you necessarily have to, you're not an alcoholic, or you know, do not abuse alcohol, but alcohol intake, excessive or any alcohol intake, can accelerate the progression of hepatitis to end-stage cirrhosis, okay? Once again, so that's one of the major recommendations, even if you have hepatitis, to avoid alcohol intake. Nutritional deficiencies, vitamin D and zinc are some of the common deficiencies with hepatitis, primarily Hep C. There are some autoimmune diseases as well, primary biliary cholangitis and primary sclerosing cholangitis, usually known as PBC or PSC. This is more of a genetic or environmental disorder, right? The bile ducts, they become inflamed and fibrose and cholestasis. So there's basically no movement of bile, the production, and then the movement of bile in the bile ducts. Bile is needed for fat absorption, so our fat that we eat, and then for our fat soluble vitamins. We see here what they are. I like, you know, I listed A, D, E, but I like to say Katie. It's easier to remember what those fat soluble vitamins are when you put them to like a nice little acronym. With this, we just need to monitor what those blood levels are and then replete as needed. So just moving more so for the nutritional management of advanced liver disease. You need to make sure that we're meeting the caloric needs and to prevent any further protein loss. Early intervention is very, very important in improving those outcomes. So, you know, if we are in like the fibrotic stage, when we're in, say, the compensated stage, make sure that we're getting proper nutrition. You see your dietitian, you see your hepatologist on a regular basis, and then refer earlier than later. One of the things also is important if we're progressing in that end stage towards transplant, making sure that we reduce any complications before liver transplant, you know, stopping that protein loss, stopping that weight loss, that we use the term cachexia. So we may see a picture, you know, you're thin here in the temple region or in the clavicle region. So we're losing a lot of muscles because of malnutrition. With our patients, so we do our calculations, you know, how many calories do you need, how many proteins and fluid. So here it's, you know, you have a little guideline from if you are compensated, just normal intake basically. But when we become a little bit more advanced, you know, the caloric needs are increased. Protein needs are a little bit, you know, increased, and then the fluid restrictions or your fluid needs really depend on where you are. If you're compensated, you know, functioning well, you're not holding on to any of fluid in your stomach, in your lungs, or in your legs, you can, you know, drink normally. But there are some patients who, you know, we do have them on, say, a fluid restriction, right? They their body is holding on to fluid say in the legs, in the stomach, which further decreases like their sodium levels. And so, you know, the doctor may put you on a fluid restriction. As I said, everyone is different and just mainly individualizing the care for that patient. So what does that look like, right? We always see these numbers, you know, 25 calories. So Jane Doe is here, right? 50 kilograms or 110 pounds. Okay, she is compensated, doing well. So this, you know, looking at her, this is where her calorie range should be. 1,200 to maybe 1,500 calories, 50 to 75 grams of protein, 1.5 up to 2 liters per day. Unfortunately, Jane Doe progresses to, you know, further decompensated liver disease. Now, you know, she's getting her ascites or paracentesis, you know, on a weekly basis or, you know, a couple of times a month. So she's losing calories, she's losing protein, losing nutrients with that procedure. Increasing her calories is important. So she's now on the higher end of that calorie, and it's also on the protein intake. Now versus 50, her needs, you know, kind of start at 60 grams of protein or more. Now we can increase this as needed. So for my patients, when they're in the hospital, a little bit more critical, then we talk about, a higher protein level. In the past, protein restriction was something that was done for patients with end-stage liver disease to help with that encephalopathy, that confusion. They've done studies that show that it's more detrimental, basically, to their health when we restrict the protein. There are a few part of the population where you can classify them as protein sensitive. And with those patients, you kind of do a normal intake. So 0.6 grams to 0.8 grams of protein, but nothing less than that, okay? So how do we get all this together? How do we get our 1,200 or up to our 2,000 calories a day? If you imagine, you're full of fluid in your stomach, and this is like for a week at a time, you don't feel like eating, you're not sitting down with the big 10-inch plate with your carbs, protein, all these things at once. We really have to break it down and make it the smaller, more frequent meals. You might have heard the term 6 small meals. What does that look like? So maybe some, eggs or and a slice of toast in the morning, okay? Or even just peanut butter on English muffin. So that's a breakfast. Then your snack could be a piece of fruit with some peanut butter on it, or some yogurt, okay? Dinner could be even, or dinner or lunch, just maybe 2 ounces of protein, half a cup of some kind of carbohydrate, and that's a small amount of vegetables, not too much at once. We get another snack in there. Kristin mentioned nuts are great snacks, okay? You get some protein, and then you get your healthy fats in nuts as well. And they're really caloric dense. So a quarter cup of nuts is about 150 calories. I don't know about you, but I get those little cans of nuts, and I can literally finish the entire thing in maybe an afternoon. You're sitting there, you're typing, you're eating. And so they're about maybe 3 or 4 servings. So right there, you over up to 400, 500 calories right there. So good when you want to maintain your nutrition, but you have to be mindful if you're watching your calories, okay? And bedtime snack, right? So, that fast in the liver is we're not able to, say, store as much nutrient as possible. So we do need to have something before bed. Once again, always try to pair with our carbohydrate and a protein together. Avoid skipping meals. And then, sodium. So for patients who have fluid issues, basically sodium and fluid go together. If you're taking a whole lot of sodium in the body's like, oh, let me hold on to this water to dilute myself. So you have to be careful and be very mindful in watching your sodium intake, reading your labels, see if it's 140 milligrams per serving is what we consider a low salt diet. But once again, working with your dietitian, she can tailor it, he or she can tailor it to you. Now, there are times when, I can't get that food in. So we do need a little bit of, as Kristin mentioned, the non-food, right? The oral nutrition, the milk-based or juice-based protein product, we might have heard Ensure or Boost type drinks. There's whey protein powder. So you can mix this powder with your preferred milk or your preferred liquid. Some patients, you can mix it with, depending on what product it is, you can mix it with juice or, maybe a non-milk, almond milk, or just even a regular milk. And then there are some protein bars that you can kind of use to supplement the intake. if we're doing a smaller portion, the protein bar could be used as part of that small meal. Okay. Once again, your dietitian can help you to see which one is best for you. We have from like 5 gram of protein bar, which I don't consider those as, that's more of just like a snack, right? So if we're looking at protein bars, I like to recommend 10 grams of protein or more. We have some that have 20 grams, we have some that have 30 grams. So it's really just looking to see what works best for you. So I mentioned before a lot of the fat soluble, the vitamins and mineral deficiencies. I'll provide Warren with this source here so that you all can have access to it. I love this tool. It literally it's from A to Z. I just picked out some of the ones that, I mentioned before regarding, say, the fat soluble vitamins. They're listed there. It talks about the foods, what's the function, where do I find it, and how much do I need. Same thing with some of the B vitamins, okay? And then additionally, folic acid, thiamine. This is one of the, with alcohol, alcohol liver disease, excuse me, thiamine is one of those nutrients that gets depleted. If we have our patients coming in, if that is the issue with your liver disease, more likely you'll be on like a thiamine supplementation for that. And we see how important it is. So moving forward, we unfortunately, we liver disease progressed enough so that we do need a transplant. When so as previously, I see our patients, so work with them prior to that transplant to make sure that they're, as healthy as possible before we go to transplantation. So the nutrition after transplant, short-term goals to make sure that we're providing adequate calories for healing. There are tons of other electrolyte imbalances. The medications are great, but they cause other things to happen as well, other side effects. So in the short term, make sure we get enough calories, protein, and then making sure we're preventing infection. Food safety is a huge thing with after transplant because you are taking those immunosuppression medications. Long-term goals will, as stated here, just healthy weight, blood sugar control, lipid health, and also good blood pressure control. I mentioned the food safety. So as a transplant recipient, you will be taking we call anti-rejection medication. Basically, that's what's keeping the body from fighting the new organ, okay? With this, you're a little bit more susceptible for foodborne infection. And the way when I educate my patients, no undercooked meats or poultry, no raw milk, raw eggs, and definitely no raw fish or sushi. We have to be mindful of different medications that we take or different foods that may interact with our transplant medication. Two of the major ones, no grapefruit or pomegranate products. So the fruit itself, the juice, or if it's in a product, okay? We also make sure that we're avoiding any herbals. Just because the biggest thing even with COVID, everyone wants to boost their immune system. So there are a lot of natural herbs and things that, it may be helpful and may be okay for someone who isn't on these type of medication, but there are so many unknowns. So if you take St. John wort or ginkgo, all these different things that may interact with your medication. So we do recommend to our patients to avoid any herbals that we have not prescribed. As I mentioned before, medication is great. It does a wonderful job. It keeps that liver healthy when you take it as you should, but there are some issues that come along with that. So Their electrolyte imbalances, potassium, magnesium's low, phosphorus is low. This is, I think all of my patients were always talking about these, watch your potassium, increase your magnesium, and so forth. Some of those medications can also, cause high cholesterol and high triglycerides. So, we look at a heart healthy diet, making sure that we're not having too much saturated fat or unhealthy or processed carbohydrate, which can lead to the cholesterol and increased triglycerides. Another big side effects of our anti-rejection medications, high blood sugars, and also we call it NODAT, so new onset diabetes after transplant. Type 2 diabetes it really goes undiagnosed many times for just the general population. And then even with that advanced liver disease, we have that insulin resistance and issues prior to transplant. Now, with the addition of these medications that affect the cells, you become a little bit more sensitive, which can push you over to diabetes. Once again, weight management, exercise, a good diet can help manage that without, so that you don't necessarily need any medication to manage diabetes. One other additional thing, weight gain after transplant. Sometimes you're on, we call steroids. So steroids increase that appetite. I always tell my patient, your weight gain is going to determine, it depends on what am I using to feed that hunger, right? Am I using Ho-Hos and Twinkies, fruits and vegetables and protein, right? To kind of help. So you may gain weight, but it's all about, what you feed the hunger with will determine the rate of weight gain. High blood pressure is also a common issue after transplant, medication side effects, osteoporosis, being on those anti-rejection medications, steroids, all can affect your bone health. Just in conclusion, so it is very important to individualize the nutrition care for our patients. Handing them that 1,200 calorie diet isn't for everyone. When I see my patients, I review what they're eating. Okay, let's change this around. We can keep this here. And the goal, really just preventing that malnutrition on the first end prior to transplant as best we can. I tell my patients, we're not gonna, you're not gonna fill in the collarbone or up here. Your temples aren't gonna fill in before transplant, but do your best to kind of prevent any further weight loss, any further muscle loss. And after we get the transplant, we just talk about and encouraging a healthy diet and healthy lifestyle. Some of those things that Kristin spoke about, watching, the healthy fats, you can do the Mediterranean diet. All those are another way of keeping that liver healthy, okay? One thing patients may not be aware of, you get that liver transplant, if we don't change our lifestyle, we can kind of end back up on that trajectory that I showed earlier of, the fatty liver and leading back to cirrhosis and stage liver disease. So it's a new lease on life. You just want to make sure you treat that liver the best you can so it can last you for the rest of your life. Thank you so much, Warren, for this opportunity.
Thank you, Carlene, so much for that. In my work at the American Liver Foundation, I'm in the support services, which is where folks could, call us. We have our helpline, which I'll give more information about at the end. But, people will call us and they'll say, I have cirrhosis or whatever. How much protein should I be eating? That's, as both of you have pointed out, those are challenging questions because it is so personal, right? It is so for that person. What do you need? And we don't want to look at generic generic listings to say, it's like I'm a runner, and I don't use a generic plan of how to run a marathon because there's not a one size fits all. And it's the same thing, I think, with food, right? So I think that's where, again, a takeaway from this here is consult a professional, right?
Correct.
Make a certified, and we always say certified, make a certified dietitian a part of your team, because just as your other care has to be personalized, so has nutrition, right?
Correct. So the registered, there are many, we see words interchangeable, nutritionists, they use it interchangeable. But you mentioned certified, but you want to look for that RD, that registered dietitian. Excuse me. So the dietitian goes to school for 4 years. We do an internship. Okay, so that could be 6 months up to, I think mine was about almost 11 months or so. And we then have to sit for our registered board, similar to like the RN, this is for the RD exam. And we have to do continuing education, for that to get certified every, stay up on things every 5 years. So it's not something to, and not everyone can do it, So I had a colleague, he's like, my fried ham degree, which is, I was like, this is not just a fried ham degree, we do that training, and then when you find your niche, right? So for me, that is transplant nutrition. I was able to, have that certification through the experience, right? So how many years and how many patients you're able to, you've been in contact with to get that certification. So we have, GI specialists, we have our diabetic specialists. So the world of dietitian really runs the gambit, whatever that disease issue is, or just for healthy living, you can find someone there. Okay.
We're seeing a lot more now, and this happened in my own primary care's practices. A lot of offices are now adding a certified dietitian right to their medical team. There was one doctor who we had on for a presentation who said, when he diagnoses somebody, say with fatty liver, then he says to them, okay, now I want you to go down the hall to room 243, and that's where our certified dietitian is, and take that next step. So those are really, in terms of the healthcare system, is what we want, right? Because as we said, especially with liver, because nutrition is your treatment, and it is so important, and yet it's difficult to understand. And so, it's not as easy as saying, okay, just have, 12 ounces of protein. Well, what is that?
Right. What does that look like?
What is that? Yeah.
What does that look like?
Right,
And
yeah.
so it's definitely important. You are correct. I know the Academy of Nutrition and Dietetics, they have those toolkits to say, approaching your primary care physician to say, let's partner with the dietitian, right? Whether it be in the office or in the community. For the work I do, the consultation work that I do, we have a lot of referrals from primary care physicians, oh, that A1C pops up over 6, or, your BMI is above that range, okay? Or that blood pressure is a little bit too high. So, here, speak with this, with the dietitian to kind of get your health back into check, basically.
Yeah, and a point that we spoke about before, which I think is important, is the psychological aspect of food, right? We call certain things comfort foods, right? And a lot of people experienced this during the pandemic.
Yes.
because we were home, and we took comfort in food. Boredom, all those kind of things have really, alcohol use certainly, but sometimes we focus a little too much, I think, in regard, because we don't want people to think, well, alcohol is the only way you can get liver disease. We hear that a lot from people who
Right.
contact us. They'll say, well, I have fatty liver, but I never drank, and so, but we want to say is, well, it's about food too. And, sometimes people, maybe a counselor of some kind could be helpful because when you're talking about a lifestyle change, that's not easy, right?
No.
Because having this healthy nutritional lifestyle, because we tell people this is not a diet. This is a lifestyle, and people might need some extra help with that. Once again, we think of that with addiction and all that kind of stuff, but it's also with food, right?
Food in itself, and that's the big misconception. We see alcohol, we see, tobacco, but food within itself can be an addiction as well. So through our training, we have those counseling classes. So there are many times when I have my clients, we're talking about what does your day look like? When you wake up in the morning, what do you have to do? What are your responsibilities? That socioeconomic environment, the psychosocial environment really plays a part on your nutrition status. So I recommend it to my patients, let's speak to a counselor so that we can improve our coping skills. So when the mind is right, everything else kind of, falls into place. And, half the time I spend time more doing some counseling versus say that nutrition, here's what you eat. But it needs to get done so that I can focus on their nutrition. So it's really of a mind-body component with nutrition.
And my final thought on this is we often get a lot of questions about supplements, and now you touched upon them, very well. But I think the way I understand it is supplements are called that for a reason, right? So because if there's something we're not getting in our diet, we need to supplement it, right? So that doesn't mean that everybody needs everything, right? Because I may be doing very well with vitamin, A and C. I'm not doing good with D, so I need to supplement that, right? So because I think there's the feeling that I just need to take a multivitamin. I need to take every supplement that's out there. And we have to be careful with that because that can, too much on the other side could be not good for us.
Correct. So there are vitamins and minerals that, it can lead to that hepatic toxicity, that acute liver failure. As you mentioned, it's a supplemental thing. So most of us are vitamin D deficient. So, we may be taking a vitamin D supplement. It's very important to have your doctor check your levels. Okay, so they can run a vitamin panel, they can run a mineral panel. Do I need E? Do I need D? Do I need vitamin C? And that's, that's one like a trigger thing for me. Like the vitamin C, you can really, with a well-rounded diet, you're getting a couple of servings of fruits and vegetables, you may not necessarily need that extra vitamin C. Vitamin D, your B vitamins, sure, a B complex, a lot of, as I mentioned before, depending on where your liver disease is and what the cause is, you may be deficient in some of those B vitamins, right? So, and the studies show that excess of it is not necessarily good. Just make sure it brings you out of that deficiency state, right? Towards that normal level. And we may need a maintenance dose, so there is vitamin D is one, you get a load-in dose for a certain time frame, and then you're on a maintenance dose further, moving forward. Generally speaking, if you have issues getting, the fresh fruits and vegetable, either a B complex or a multivitamin is okay. Okay. Mega dosing and especially like the fat soluble vitamins that can cause, issues with the livers. You can have issues with your kidney. I always, the term expensive urine, basically, because what the body is not able to absorb it's just going to go right through down the toilet. So, you know, I say, save your money.
Right.
You know, that's all I get. What can I take this? Ask
Right.
me before you purchase it, not after you purchase it. But it's just a fine balance and act. You know, you try your best to get your vitamins, your fruits and vegetables in. If maybe it's your lifestyle, maybe it's your disease process that you're not able to, a B12, a B complex or a multivitamin is kind of where you start. But for folks who do have liver disease, just ask your doctor, can you check my vitamin and mineral panel, see where I am, and then replete as needed.
That's, you know, I've heard that phrase before. So I heard someone say that Americans have the most expensive urine in the world. So the rule of thumb is get it from real food first. Then if you need the supplement, then you get the supplement. So,
correct.
Well, you know, you guys have been so wonderful today. I really appreciate your time. And what we do with these presentations is that when we do post them to our YouTube channel, we do offer the ability to for people to view them in segments. And so therefore, the same will happen with this presentation today, that people can kind of go in and out to the areas that would be most important for them, as well as we hope will watch the entire presentation. But again, Carlene and Kristin, I want to thank both of you for your time again and being with us today. And I already have ideas for us for some future work that we can do together. So we really appreciate it. And all of you who will be viewing our presentation today, and those who have been following us on our Ask the Expert series, we thank you. As we always end our presentations, we say that if you would like more information about liver disease, liver wellness, and much more, go to our website, which is www.liverfoundation.org. You can also use our national helpline. We have email, we have live chat, and sometimes it's better if you just call us because certain things are easier to discuss by phone. And so we invite you to do that. Also, if you'd like to see the previous episodes of our Ask the Expert series, you can go to our YouTube channel where we not only have Ask the Experts, but we have many other of our educational presentations. So Carlene, I do want to ask you though, where can folks find you? I believe you had your website up on one of the screen, but if you could tell us, what is the place where folks can get more information?
For personal consultation, I do work for Nutrition Unlimited. You can search Nutrition Unlimited rd.com. Okay, I'm just one of the consultants there, so you can ask for me specifically if you wish. But it's a great group of dietitians that really focus on, you know, cultural sensitivity, and then just really individualizing your care. It's on Instagram as well. So Nutrition Unlimited is where you can get my services.
Great.
Outside of liver transplant.
Okay. So it's not only transplant that you do have other types of consultation.
Yeah. So, you know, my 9 to 5 is primarily with the transplant center. So if you do happen to come through there for transplant, I get my services there. But as you know, community service as well.
Okay, great. Well, good. And you're in Philadelphia.
I am in Philadelphia. Yeah. So if you go to eatright.org, you can that's the nutrition association. You can just type in your area and for the specific nutrition needs. So eatright.org, and you type in our names and it should pop up.
Yeah, we eatright.org. We also give that to everybody who asks, because that's the place to go and to locate the professional type of person that everybody needs. So, okay, well, again, thank you, and thank you, everyone, and we hope that we'll see you again on another episode of our Ask the Expert series.
Thank you, Warren.
Thank you.